We've now moved to doing a cognitive assessment annually on everybody, just like we would do an MRI on each patient. We're doing a cognitive screen, about an hour and a half cognitive screen on everyone, so we can follow them, because a single assessment doesn't help very much, but following over time certainly would be another metric, which brings us into the last topic we discussed, and that is outcome metrics. You know, what are we actually looking to handle? We've alluded to this a little bit as we've gone along, and even the idea that maybe we're not measuring everything we can. I mean, we certainly have relapses we look at, and we've done a really good job at dropping relapse rates. Right? That's been the primary outcome measure for all of our therapies, and we're very good at it. Progressive disease, we're just starting to open the door to having these modest effects on progression as measured by EDSS. But where do we go next? What do we need to monitor to get to nothing going on? No disease activity, no progression. Clyde?
Well, I think, if you look at all the clinical trials we've done to date, they've all measured those particular metrics: relapses, disability progression, and MRI. And I agree, we've done a good job in terms of being able to suppress disease activity, but you still have the problem of people progressing independent of these other metrics. They're not having relapses anymore. They're not having any evidence that we see of any MRI activity with GAD lesions or new T2 lesions, but they continue to slowly progress, and we call that the degenerative phase or progression of the disease. And I think that maybe the neurofilament light chain will help us in that arena. I'm not convinced that that necessarily will be the answer to all this. But I do think that, when patients come into the office and we have to make the determination, do we think that somebody's on the right therapy, or should we switch them to something else? When it's obvious, right? They've had clinical relapses, they didn't recover, or it's a significant amount of new disease activity on their MRI, it's easy. We just say, we're going to switch you to something else. But we have no guidelines in this arena. We don't really know what's the best thing to do next, and that's why it's important that we understand the mechanism of the drugs and know what sequence we may need to go to next. We may go up in efficacy. So, for us, I think as practicing clinicians and for the people who we're talking to, it's not an easy piece for us, because we don't have the metrics to really answer these questions. We have some, and we're able to act on what we have, but we're missing a lot of the disease activity that's happening below the surface, at least below what you can see on an MRI.
You mentioned doing cognitive function battery once a year. Certainly, symbol-digit modality test is just a few minutes, is very easy to do on a regular basis, minimum once a year, maybe twice a year. 25-foot time walk, easy to do, and from the point of view of gait, you really can pick up issues there. 9-hole peg test, not that difficult to do. We haven't spoken at all about the visual system. Not yet ready, but optical coherence tomography, I think, holds real promise, and low density visual testing is much more sensitive than the regular. And then, of course, we haven't really spoken about non-conventional imaging techniques. Let's talk about volume loss, brain volume loss. There are now commercial, and we're beginning to see it, we're getting volume measurements and segmental and cortical and thalamic, et cetera. Not ready for prime time, I think, on the individual basis, but maybe in the not too distant future, that will be a meaningful thing to follow if we are correcting for all the factors that can influence it tremendously.
We need to be able to detect by imaging those cortical lesions that until now are only detected pathologically. And that's really, I think, critical in predicting disability.
I think that a very important point was made, and it's maybe hidden, that's why I want to kind of bring it out. 9-hole peg test, 25-foot walk, symbol-digit modality test, these are all quantifiable tests. Where I think we need to go is to move from a purely qualitative exam in multiple sclerosis to have some quantitative measures when we evaluate patients over time, because this will also be very important as we determine the value of multiple sclerosis therapies as we determine the value of multiple sclerosis care.
So I think a very important point was just made, and I'd like to bring something out, which is devices, wearable devices. So we haven't sort of explicitly mentioned them, and I think that how to interpret the data, I think we need to learn better, but it seems intuitive that some of these things which can be worn at home and over time will give us a better measurement set.
No, I think that's true. If you have a week's worth of walking data versus just the 25-foot time walk, that's going to be very useful.
The piece that I think, and these are all outstanding points, the thing that we don't have in this MS world that we live in is that we don't have comparative data for these metrics. And that's what we need. We need to be able to do these in clinical trials as comparisons, because when we're going to make a decision that somebody's not doing well on whatever therapy they're on, we want to go to something else, just like you have relapse rate or you have MRI lesions, you have some data that says this might be better than that. We need those kind of comparison studies for these new metrics.